Good evening, everyone, and welcome to this Prostate Cancer UK webinar, Localised Prostate Cancer, How to Navigate Your Treatment Options. I'm Jonathan Kay, and I'm the Health Information Service Lead at Prostate Cancer UK, and I'll be your host for this evening. Before we get going, I just need to go through a little bit of housekeeping. Firstly, we're here on a Zoom webinar, so this is slightly different to a regular Zoom meeting in that you'll only be able to see the hosts during the webinar and the slides. Your cameras have been turned off and your microphones are on mute, so you don't need to worry about making any background noise or anything like that. As we're going through, if you've got any questions for the panel, please use the Q&A function to submit them. I'm very glad that we have Lara and Meg here from our specialist nurses team, and they're on hand to respond to some of these within the chat. We'll also have dedicated time for a Q&A discussion at the end, where we'll go through some of the more detailed questions. Please don't include any detailed personal information in your question, otherwise we won't be able to answer it. We can't give any health advice on individual cases, so please also note that the nurses' answers will come through on the chat as we're going through. We're sorry if we don't get to your questions this evening. If you're left with any urgent questions, remember that our specialist nurse services is available Monday to Friday, 9 a.m. to 5 p.m. We'll aim to collate the unanswered questions and answer them in a summary email in the coming days. Please note that everything in this webinar is intended as general information for men with localized prostate cancer. It'll help you understand and navigate your situation better, but it doesn't constitute medical advice. Importantly, we'll be covering some issues that people might find challenging. If you find it difficult to listen at any point, don't worry about that. You can, of course, step away. We'll be circulating a recording of the webinar afterwards so you can catch up with it in your own time. I'm delighted to be joined by a wonderful panel encompassing clinical expertise and lived experience. I'll let them introduce themselves very briefly and hopefully they'll be appearing on the screen right now. So I'd like Grace to introduce herself first.
Hi everyone, my name's Grace and I'm one of the specialist nurses at Prostate Cancer UK.
Thank you, Grace. I'll pass you over to Andy now.
Good evening, everybody. My name is Andy, and I've been a prostate cancer UK volunteer for the last 15 years.
Thank you, Andy. And now, Gary.
Hello, my name's Gary Harding. I've been a peer support volunteer for the last just over a year now.
Thank you. And finally, Peter.
Hello, I'm Peter. I'm a consultant oncologist working at the Christie Hospital in Manchester and Mount Vernon Hospital in North London.
Thank you. So Grace will be back with us with our first talk very soon. But first, we'd just like to do a very quick poll as we'd like to know more about our audience that we have with us today. So just bear with me a second. This should hopefully appear on the screen now. So as I said, we want to know more about our audience today so that we can improve our future webinar content. Please, can you select any of the following that are appropriate to you? And I'll just give you a few minutes to be able to answer that question before we move on. I'll just let that run for a little bit longer. Okay, great. Thank you. So looking back at that, it's good to see that the people in the room are the people that should be here on this webinar. You have lots of men that have been diagnosed with prostate cancer but have not started treatment yet. So you're at that critical stage of deciding what treatment is right for you. It's also good to see that we've got a healthcare professional in the room viewing our content as well. So thank you everybody for taking part in that poll. So during this webinar, you'll hear about some of the possible treatment options available to men with newly diagnosed localized prostate cancer. We'll also talk about the various forms of support that you can use to help decide which treatment is right for you. This can range from support services like those offered by Prostate Cancer UK, as well as talking to friends and family and even digital information tools. You'll also hear how men like yourself made their own treatment choices as part of their own prostate cancer journey. So I'm now going to pass you over to our clinical nurse specialist, Grace, for her talk.
Hi everyone. So I thought we'd get started with a brief overview of the prostate, what it does and what localized prostate cancer means. This can help understand why different treatment options are considered and the different side effects that could occur. So the prostate is a walnut-sized gland that sits within the pelvis, just below the bladder, the rectum sitting directly behind it. The urethra, or wee pipe, runs through the middle of the prostate, and the seminal vesicles sit just behind the prostate. The main job of the prostate is to produce some of the fluid that mixes with sperm from the testicles to make semen. Localized prostate cancer is cancer that's inside the prostate and hasn't spread to other parts of the body. It can sometimes be referred to as organ-confined prostate cancer or T1 or T2 prostate cancer, which I go on to explain a bit more about on the next slides. Understanding your test results. There can be lots of information when you first get diagnosed with prostate cancer. Being able to understand what some of these test results might mean for you can be helpful, as these results will help inform on your possible treatment options. Usually your case will be discussed in an MDT meeting, multidisciplinary team meeting, where different healthcare professionals look at all of your scans and results, such as biopsies and blood tests, to give their professional recommendations on what treatment or various treatments would be best for you. They will use these grading systems below to help categorize your type of prostate cancer. Usually with localized prostate cancers, where different treatment options can be considered, there isn't a significant rush to make a decision, and men can then take some time to process and make an informed decision. The most common test results you will see or hear discussed are Gleason scores, TNM, so tumor nodes and metastases classification staging, and CPG, Cambridge prognostic groups. In the next slides, I will go through what these might mean. We can't interpret individual test results, and your hospital doctor or specialist nurse can help you if you have any specific questions. So Gleason scores. Gleason score is commonly used within prostate cancer diagnostics. Simply, the Gleason score tells us how aggressive a prostate cancer is, which refers to how quickly it might grow, as well as the risk of it spreading outside the prostate. Hearing the term aggressive can feel concerning. We know that in general, prostate cancer is one of the slowest growing types of cancer, and even aggressive prostate cancers is unlikely to change rapidly. An aggressive cancer has the potential to spread, and there is usually time to consider treatment options without too much urgency. The Gleason score comprises of two numbers added together to give you a value of between 6 and 10. 6 being the least aggressive type of prostate cancer, meaning that all of the cancer cells found in the biopsy look likely to grow very slowly, if at all, and 10 being all of the cancer cells found in the biopsy look likely to grow more quickly. The first number reflects the grade of most of the tissue, and the second number is the highest grade within the sample, tissue taken from a biopsy. The lowest individual grade will be a 3, and it goes up to a 5. So, for example, a Gleason score of 6 will be a 3 plus 3, and a Gleason score of 10 will be a 5 plus 5. The Gleason scores of 7, 8, and 9 can be expressed in two different ways and is an important factor to consider. As you can see on the side, let's take a Gleason 7 as an example. This can be expressed as either a 3 plus 4 or a 4 plus 3. A 4 plus 3 Gleason score would be considered a slightly more aggressive prostate cancer than a 3 plus 4, as the first number tells us the grade of most of the tissue found, and this is the higher grade of 4. Gleason scores are considered an important diagnostic factor. However, treatment options will not be solely based on Gleason scores. Other considerations, such as where the prostate cancer is in the prostate and individual medical history, will be taken into consideration. So on to T, N, and M stages. You might also see or hear this written down on hospital letters. This is a classification system that is used to work out if your prostate cancer is localized, locally advanced, or advanced. So firstly, the T stage, it refers to the extent of prostate cancer within the prostate and if it has spread to any nearby tissue, such as the seminal vesicles. There are 4 T stages: T1, T2, T3, and T4. Commonly, T2 is where the prostate cancer is confined or localized to the prostate, and T3 refers to the prostate cancer starting to break out of the prostate capsule. For more specific information, this could be discussed further on what this might individually mean for you with your healthcare team. The end stage refers to if there is any spread of the prostate cancer to nearby pelvic lymph nodes. Lymph nodes are a common place for prostate cancer to potentially spread to, and they are part of the body's immune system, helping filter substances in your body and helping to fight any infection and disease. The end stage can be reflected as NX, so lymph nodes not assessed, N0, no regional lymph node involvement, and N1, pelvic lymph nodes present. Finally, the M stage refers to the spread to other areas of the body. You'll likely hear this called metastatic prostate cancer. If there are no distant metastases found, it will be expressed as M0. If this was not assessed, referred to as MX, and if distant metastases are found, M1. CPG, Cambridge Prognostic Score. So the CPG is a slightly newer system where the Gleason score, PSA, and T-stage are then combined to give a score between 1 and 5. It can then help identify higher or lower risk prostate cancers and guide healthcare teams in deciding on treatment options. From the slide, you can see the different inclusion criteria for different CPG groups. For localized prostate cancer, you will likely have a CPG score from 1 to 3. If you have any concerns around understanding your test results, you can always ask for clarification from your healthcare team. Look at further information on all these tests at prostatecanceruk.org or call one of the specialist nurses at Prostate Cancer UK for further information and support. So on to an overview of localized treatment options. This slide gives an overview of all the different treatment options potentially considered for localized prostate cancer. Some men might not have the option of all these treatment options, dependent on several factors such as availability, individual diagnosis, and their own medical history. On the next slides, I'll give a brief overview of what they might involve. However, when deciding on a treatment option, it's best to look further into what's involved, the advantages and disadvantages, and possible side effects. When considering side effects, it's important to say that not all men will experience side effects in the same way, and some might experience more or less than others. At Prostate Cancer UK, we have web pages and fact sheets on all these treatments that answer these questions, and you can, of course, always call our specialist nurses for more information and support on different treatment options. So, active surveillance. It is a way of monitoring early prostate cancers. It means that for men with low risk, localized prostate cancers that might never grow or spread, they can opt to be monitored rather than have radical treatment straight away. Some men can stay on active surveillance all their lives, not needing treatment, or be on active surveillance till a change in their prostate cancer is detected, at which point radical treatment can be considered, usually with curative intent. It involves regular PSA monitoring and interval MRI scans, potentially with further biopsies considered dependent on individual circumstances. Watchful waiting is a way of monitoring prostate cancer that isn't causing any symptoms or problems. The aim is to keep an eye on your cancer over the long term and avoid treatment unless you get any symptoms or signs that your cancer is growing. If this does happen, you can start treatment to control the cancer and improve symptoms rather than a radical treatment to cure the cancer. Watchful waiting is usually considered if you are diagnosed with prostate cancer at an older age. This is because we know that nearly 80% of 80-year-olds and 90% of 90-year-olds will have some form of low-grade prostate cancer that is unlikely to cause any concern within their lifetime, and that men are more likely to die with it rather than from it. Watchful waiting can easily and often be confused with active surveillance. They are, however, different in their approaches, and it's good to clarify with your healthcare team if you are confused about whether you are on active surveillance or watchful waiting. So first up for the radical prostate cancer treatments is surgery, known as a radical prostatectomy. This is probably one of the most common treatments for localized prostate cancer. It is where the whole of the prostate gland and the seminal vesicles are removed surgically. It's commonly done via robot-assisted keyhole surgery. Recovery time is usually between 6 to 12 weeks, and a catheter is usually placed for around 7 to 14 days after surgery. Some common side effects can include incontinence and erection problems. Dependent on how well and fit you are and your individual medical history, it is not normally considered a treatment option for men over the age of 75. Next up is hormone therapy. It works by stopping the production of testosterone, which stops the growth and spread of the prostate cancer. It's a treatment considered for different types of prostate cancer, not just localized prostate cancer. It usually comes in the form of injections that last approximately 3 months, though some brands of hormone therapies can come in tablet form. Within localized prostate cancer, it is usually given in conjunction with external beam radiotherapy, which I go on to discuss on the next slide. Men can be on hormone therapy for varying lengths of time, but usually it's considered for a few months before treatment, throughout the radiotherapy, and sometimes for a period of time after radiotherapy. Common side effects can include fatigue, loss of libido, and hot flushes. External beam therapy is where high-energy X-ray beams are used to target the prostate from outside the body to kill the prostate cancer cells. It treats the whole of the prostate gland. It's commonly used with hormone therapy, but it can be used as a standalone treatment. You will usually have a CT planning scan before treatment to ensure accuracy of the treatment. It usually involves up to 20 radiotherapy sessions given over a 4-week period, Monday through to Friday. It is usually no longer than 20 minutes a session. You will likely be asked to have a full bladder and empty rectum before radiotherapy treatment, and some common side effects from treatment can include fatigue and bowel and urinary problems. Due to potential bowel side effects, if a man has any inflammatory bowel disease, this treatment might not be considered. SABR, or stereotactic radiotherapy, is another type of external beam radiotherapy. The main difference between SABR and external beam radiotherapy is that SABR delivers a higher dose of radiation at each treatment session and is given in fewer sessions overall. The course of treatment is therefore shorter compared with standard external beam radiotherapy. You will still have a planning scan with SABR, usually as few as 5 over 1 or 2 weeks. SABR is not available in every hospital and is newer than other types of radiotherapy, and therefore we don't have as much research in how well it works in comparison to other treatments such as surgery and external beam radiotherapy. So moving on to low-dose rate brachytherapy, or also known as permanent seed brachytherapy, is a type of radiotherapy where tiny radioactive seeds are put into the prostate. They are very small, roughly the size of a grain of rice. The seeds stay in the prostate forever and give a steady dose of radiation over a few months. After around 8 to 10 months, almost all of the radiation has been released. This treatment usually involves 2 hospital visits, a planning session, and treatment session where the seeds are placed. For the treatment session, you will be placed under general anaesthetic, and some common side effects can include urinary and bowel problems and erection problems. Permanent seed brachytherapy can be given as a standalone treatment in localized prostate cancers, but it can also be given to men with more high-risk locally advanced disease as a brachytherapy boost, where it is used initially before external beam radiotherapy and hormone therapy is given as a treatment. So finally, focal therapy. This is the treatment where various types of energy, so ultrasound, heat, or freezing, are used to destroy prostate cancer cells. Unlike some of the other treatment options we've discussed that treat the whole of the prostate gland, focal therapy targets specific areas of prostate cancer within the prostate. A common focal therapy treatment you might hear about is HIFU, high-intensity focused ultrasound. You will usually have a general anaesthetic for this treatment, where a probe is used via the back passage to deliver the high-intensity ultrasound energy. The most common side effects can be urinary problems and erection problems. There are some cases where HIFU may not be suitable, the most common being if you have a large prostate. Focal therapy is a slightly newer treatment in comparison to some of the previous ones we've discussed, and as such, we don't have the same long-term outcomes, and it's not available in all hospitals. And dependent on where you might live, you might have to be referred to another hospital to access this treatment. So this is my last slide. This next slide I felt was really important to include, and my section will conclude here before we have our excellent volunteers and guest speaker. I often speak to men about treatment options, and the most common question my colleagues and I get asked is, I'm not sure what to do, which is the best treatment for me, and how do I know I'm making the right decision? It's important to reflect that this is a hard decision to make and you aren't alone in feeling overwhelmed by all the information and feeling slightly lost in trying to make the best treatment decision for yourself. There is no one best treatment option. It will come down to making an informed choice, having read through all the information about what the treatments include and deciding on one that is best for you, whether that means it would fit better around your family life, managing your mental health, weighing up different side effects that you might be able to manage better than others, and how you might feel in how treatments are given. It's likely that you'll never feel 100% in a treatment decision, as unfortunately we can't see into the future to see how treatments will go and if you will be affected by side effects. But by being informed by all the information and help from your hospital treating team, and if you need any information and support from Prostate Cancer UK, hopefully the decision can feel less overwhelming. Thank you.
Thank you, Grace. That was a really clear overview of the possible treatment options that men with localized prostate cancer may have available to them. I'd now like to invite Andy and Gary back to the webinar to talk about their prostate cancer journeys, how they decided on the right treatment options for them, and also talk about their work that they do with the peer support service here at Prostate Cancer UK. So to start things off, Andy is a retired civil servant who was diagnosed with prostate cancer around 15 years ago when he was 45. Since then, he's done lots of work for charities to raise awareness of prostate cancer, which has resulted in him being awarded the British Empire Medal in the New Year's Honours List. Gary, who retired in 2017, having previously worked for Marks and Spencer's in textile manufacturing, was diagnosed in 2021 at the age of 62. Like Andy, he's an active member of the peer support service. So to start things off, I'd like to come to you first, Andy. How were you first made aware of prostate cancer and what prompted you to get checked out at your GP?
Well, I first became aware when my own father was diagnosed with prostate cancer in December 2010. We were aware that family history put me in one of the 3 high-risk groups because my paternal grandfather had also had prostate cancer. So that's the reason I went to my GP. I knew I was under the magic age of 50, but I wanted to get checked out. I wanted that peace of mind, which ultimately I didn't get, but that was my reason for going.
And can you tell us a little bit about the actual diagnosis process at that point? Because admittedly, it was 15 years ago. It was quite a different journey. But how did you go from initial talk to the GP to being told you had prostate cancer?
I started with an initial PSA test, which was slightly high for my age. I then went back a couple of weeks later, had a second PSA test, which indicated that the PSA level had risen. So that subsequently led to various CT scans, bone scans, and a biopsy as well, in which they took 20 samples through the back passage, transrectal biopsy, it's known as. And when those samples came back, they indicated that all 20 samples were cancerous. And it was at that point that the actual diagnosis was given.
Great, thank you. Thank you for sharing that. Gary, I'd like to come to you now because I know your situation was a little different because your diagnosis occurred almost by chance as you were being treated for other symptoms.
Yes, yeah. I had a problem with urine retention, and I was rushed into A&E one evening, and they did all the checks in there, and they found that my prostate was slightly enlarged. So I had a catheter fitted that particular night. So after that, very shortly, I went to see the urologist, and he tried me with medication to see whether that would relieve the symptoms. It didn't, so he organised what we call a TURP operation, and where they basically just kind of clear your urethra through the prostate, so you can pass urine a lot better. he took a biopsy as I had the procedure, and it went to the lab. It came back, and that's when they found Gleason 6 at that time. So he decided to pass me on to the urologist who deals specially with prostate cancer. And 3 months later, I had to wait about 3 months after that before I had an MRI. The MRI showed insignificant, didn't really show anything at all, to be fair. But I had the biopsy very shortly after that, and they found Gleason 7, 3+4. Fortunately, it was all it was in about 2 or 3 areas. I had about 48 samples taken, and it was luckily for me, the diagnosis, it was in the middle of the prostate. So that kind of, that's how I was diagnosed.
Great, thank you. And yeah, I now kind of want to take you both back to that obviously very challenging, difficult situation where you've just been told that you had prostate cancer. But kind of what treatment choices were given to you both, and how did you decide which one was right for you? Gary, I'll come to you first.
Yeah, I was offered 3 options. It was active surveillance because it was at the it was localized. It was in 2 of the areas, and he offered active surveillance. He offered me radiotherapy, and he offered me surgery. My decision was to take surgery, robotic surgery. I just didn't want the thought of cancer being left, and I think managing, for me particularly, personally managing prostate cancer, which a lot of men do, and they live with it fine. For me, I'd be thinking, look, is this the time when my PSA's gone up? So that I just wanted to get rid of the cancer basically, and I went for the surgery.
Great, thank you. And yourself, Andy?
I was given 2 treatment options. I was given surgery, which, unlike Gary's, was not robotic surgery. That wasn't available to me at the time. And the second treatment option was hormone therapy combined with radiotherapy. And I actually plumped for the latter because I made the mistake of consulting Dr. Google and came up with all the horror stories. And being a youngish man and with young children, I didn't want to go through the potential horror stories that were on offer. My oncologist at the time said that whichever treatment option I chose, whether it be the surgery or whether it be the hormone and radiotherapies, would be beneficial to me and have roughly similar results.
Great. I'm glad you touched on Dr. Google there, because obviously it's such an easy thing to do, is head straight to Google and look for your answers. But I think, and we'll probably come on to this much more in the talk moving forward, it's really important to find trusted sources of information, be it the NHS, be it Prostate Cancer UK, or some of the other cancer charities that are out there. Yeah, like I said, you've kind of touched on that a little bit already, Andy, but what support did you use in helping you to make that decision, be it charity ones or, within your own network of?
Well, I wasn't fully aware of Prostate Cancer UK at the time of my diagnosis. And once I was given my diagnosis, I was allocated an oncology nurse. So she was able to provide me with literature, which came from Macmillan. She was also able to provide me with verbal advice based on the questions that both I had and my wife had regarding the various treatment, the 2 treatment options that were available.
Great, thank you. And Gary, what kind of support mechanisms did you use in making your decision?
Well, sure. Well, straight after when the urologist told me I've got Gleason 7, 3+4, the oncologist was in that particular meeting. We left the discussion, and she gave me the information and said, "Look, read through this. You've got options," which the urologist obviously made
think we're having some connection problems with Gary. Let's just see if he can manage to come back. If not, we'll have to move on to the.
Clear to me.
Oh, he's back. Sorry,
And
Gary.
what I did, I'll be off in a minute. What I did, I got the information from the urologist. Are you there? Can you hear me?
You cut out, but I think you're back now.
Back now, yeah. Somebody just tried to call me. Sorry about that.
It's okay.
Yeah, so I got the information from the urologist, and I went home, I read through it, and I come across this the address Prostate Cancer UK, where there was a number there. And what I did after a week or two thinking about it, I thought, well, I'll give them a call. And it's the best thing I actually ever did. And I got through to speak to the nurses, and they took me through, told me what my diagnosis was, and they explained and made it really clear what it meant, because I didn't really know what it meant. Gleason 3+4, 4+3, it just it wasn't clear for me. And they told me the likely situation, what I was in, which from the previous slides, what we've just heard, what's high, what's low. And to be honest with you, it made it really clear what situation I was in. And then she offered me, a talk to the peer support member, like what I am today. So I got a call. I said, yeah, that'd be great. I got a call. I can always remember this guy from Leeds. He called me, and he had actually had surgery. He had the robotic surgery, and we had a good discussion and made it really clear. I asked all the questions about side effects, what it felt like, how long did it take you to get over it, and have you recovered? And then a couple of days later, I got another guy call me who had radiotherapy, and he did the same thing. And from having the discussions from different guys who'd had different types of treatment, it helped me make my decision. I was clear, it was the right thing for me. So yeah, best thing I ever did. Give him a call.
Right, that's really good to hear. Yeah, and you've touched nicely onto the kind of peer support service. So I'm glad you gave a little bit of an introduction to that. So I wanted to just kind of ask you both kind of why you wanted to sign up for the peer support service and what you get out of it, as a volunteer. Andy, I'll come to you first.
Well, I signed up for the peer support service because I know I did struggle to make a decision. And if I'd have been aware of prostate cancer UK at the time, I would have made a phone call to the specialist nurses. So I wanted to give something back, and it's a very difficult decision to make. Do I go for surgery? Do I go for other treatment options that have been given? And I just wanted to help people, try and smooth that journey as much as possible. I can't make the decision for them, but at least I can answer any questions based on my own experiences. That was the reason I wanted to join peer support.
Brilliant. And yeah, I know we really appreciate it as a charity. Volunteers like yourself and the men that are using the service, give brilliant feedback. Gary, again, is there anything you'd like to add to that? Any reasons why you wanted to?
It's similar to Andy. Look, it really, really helped me. It did. And what it made me, the reason I wanted to do it was because I thought, well, I can help, help guys who are in the same situation as me. And reassure them, not really tell them what they should have done. That's obviously up to them to still decide. But I can share my experiences off back of the treatment I've had, and so they're absolutely clear. And I've done it many times now. Spoke to men, and they've been really, really. That's the great thing is it makes you feel great, because that you help people, and they come off the phone. 90% they come off the phone were really, really grateful, and I'm sure it does help them make the decision.
Yeah, I'm sure it does. My next question to you both is probably the million-dollar question that a lot of people watching this webinar are thinking right now is, how things are going now. Do you have any regrets about the treatments that you went through? Is there anything you wish you'd done differently? I'll come to you first, Andy.
I've got no regrets whatsoever. My treatment appears to have worked for me. I was signed off after the magical 5 years by my oncologist. I still have an annual PSA check purely for my own peace of mind. My PSA at its highest was only 7.2. So in the grand scheme of things, it's not fantastically high, but it was above average for my age at the time. My last PSA test in December 2025, it was 0.38. And my PSA has been on a downward trend ever since my original diagnosis. So I've got no regrets whatsoever.
Brilliant. That's so good to hear. And yourself, Gary?
No, I'm absolutely 100% clear. I made the right decision to have the type of treatment I had. My PSA from day one, really 6 weeks I think after the operation, is read at 0.01, classed as undetectable, and it's been like that, every time I've been for a PSA. So, like I say, I'm in my 5th year now, so it's I'm really, really, really pleased, because at the beginning I was obviously worried about it. So
Yeah,
no,
of
no,
course.
absolutely no regrets whatsoever. And like I say, it does help when you talk to somebody who's gone through it, and it helps you, when you make the decision. And yeah, proof's in the pudding.
Thank you. Okay, so my last question to you both now is, what advice would you give to men who have just been diagnosed with prostate cancer, who are thinking about their treatment choices and what's available to them? Andy, I'll let you go. I didn't nominate one of you then, sorry. Andy, you
All
first.
right.
Okay. I would seek advice from the known sources for cancer, prostate cancer UK, speak to the specialist nurses. If you've got treatment options, they can arrange for somebody who has had one of those treatment options to give you a call back, because I don't think there is any experience for a life lived. And to hear it straight from the horse's mouth about how, in my case, radiotherapy and hormone therapy affected me, it would be invaluable. It's not a decision, but at least we can make sure they are well informed before they make that decision themselves.
Great, thank you. And Gary, any more
Yeah.
thoughts?
First of all, don't read Mr. Goodall. Keep away. That's the first thing I'd like to say. It just clouds, it can cloud your mind. Ditto, same as what Andy's just said, is speak to the peer support group. Speak to guys who's had the operations, and just, like I mentioned before, just it helps you make that right decision. You can't be talking to somebody who's lived and breathed it.
Of course, of course. Okay. So thank you very much for taking your time to come on this webinar and share your story with the men on the webinar. We really appreciate it. Getting that first-hand insight from someone that's gone through that journey, is so important. Just like to remind everybody on the webinar that if you've got any questions, you can submit them through the Q&A section of the webinar here, and both Andy and Gary will be sticking around for any questions that you might have for them at the end of the webinar. So moving on now to our next part is I'd like to introduce Professor Peter Hoskin to the webinar. So Peter trained in clinical oncology at the Royal Marsden Hospital in London and has been a consultant in clinical oncology at Mount Vernon Cancer Centre since 1992. He's a professor in clinical oncology at the University of Manchester as well. So he's a man with a wealth of experience of treating men with localized prostate cancer. He's also been heavily involved in the development of the East of England Cancer Alliance's Knowing You options, which is an online tool for patients with newly diagnosed prostate cancer. And he'll be talking about that tool as part of his talk tonight. So, Peter, it's over to you.
Thank you, Jonathan. So the first slide here may seem a little bit trivial, but I have consultations with men who are in the same position as you probably all are, having been told you've got prostate cancer. You're coming to see the oncologist. You don't know what that's going to entail. You're probably very anxious. You're probably quite frightened. And I see part of my role is to unravel some of that mystique that's around the diagnosis. So one of the things I'll tell my patients is that it's not a fatal form of prostate cancer for most patients who present with localized prostate cancer. The ones we've been hearing about, Gleason score 6, Gleason score 7, particularly 3+4, it's unlikely you'll die from prostate cancer. Furthermore, it's almost certainly you'll die of something else, and I'll show you some data to support that in a moment. So I think it's important that patients realize this is not something that's of immediate danger to them, but is something that needs to be treated, to invest for the many years ahead of them. The other problem is that any active treatment I offer can have side effects. And unfortunately, those side effects may not be temporary, but may have lifelong implications. And very often the choice of treatment is based on those lifelong implications rather than any other considerations, because as we've heard, essentially all the treatments we would offer will have roughly the same cure rates, very high cure rates, but it's very difficult to suggest one treatment would have a better cure rate than another. We'd be pretty stupid if we were to offer you treatments that were less effective than any one particular one. But the other thing to emphasize is that most men will only have minor side effects. There will be a small number, maybe 3 or 4 or 5%, who will have troublesome side effects that interfere with their lifestyle. But that means 95% of men will come through with only minor changes in some functions or indeed none at all. So on the next slide, which I'm waiting for because I think I'm not moving them, but perhaps I am. Hannah, can we have the next slide, please? Yeah. This is just to try again, put in context this problem of trying to explain to you what a risk is. A risk is very, very low, but risk is associated with measurable variation. It includes future events where data is available, but patterns can be observed and potential outcomes can be modeled. So I can tell you the data. I can tell you there's a 30% risk of minor side effects, and a 5% risk of more severe ones, and a 95% chance of cure. But that's very difficult to put in context, just to throw those numbers out. And I recognize that, but many people like to hear the numbers. The problem is that you're dealing with uncertainty. And uncertainty exists when the information is incomplete, which it often is. It's ambiguous, it's rapidly evolving. Some of the newer treatments, as we've already heard, we haven't got long-term information on. And so what you're trying to do is balance the likelihood of disease control, and perhaps more importantly, because we tend to be reassuring and say, don't worry, we can cure your cancer, but you may have to live with these problems, the incidence of side effects. And this question, will you be the one who gets the severe side effects? And that, of course, is imponderable. If we move on to the next slide, we'll see some of the data which supports those statements. So here you see long-term outcome. These are men undergoing active surveillance in Sweden. So these are men who were just watched very carefully. And what you see there are the outcomes over 25 years. Okay, so a 25-year span. And I don't think you can see my pointer probably, but if you just look at those, if you take a man aged 60, 65 with low-risk prostate cancer, there's a 10% or less risk of dying from prostate cancer in the next 25 years, assuming you don't die of something else, of course. And if you're aged over 70, that risk is down to 6 or 7%. So the likelihood of death from prostate cancer, if you live for 25 years, which of course most men diagnosed in their 70s certainly won't be, is only a few percentage. If we can move on to the next slide, we'll see that this is what we found in a large study in the United Kingdom. And I don't know how used people are to looking at these sort of survival curves, but what you see on the line that comes out of that curve is a straight line going across at about 90, just over 95%. And actually there are 3 lines in there. One represents patients who had active surveillance, one represents patients who had radical prostatectomy, and one represents patients who had radiotherapy. And these patients were randomized. They were very brave. They had the diagnosis and they were approached and said, we would like to enter you into a trial because we don't know which is best. Are you prepared to be randomized? And fortunately, enough of them did. Several, you see there, 1,600, so getting on for 2,000 patients, accounting for those that aren't in the curve, agreed. This was a national study across the United Kingdom, so these are patients relevant to those we're talking to today. And you see there's absolutely no difference in survival. And this is cancer-specific survival, so that's death from prostate cancer. And if you look at the box on the right, you have a 97% 15-year course-specific survival. What that means is there's just a 3% risk of dying from prostate cancer over the next 15 years. Slightly different if you're a younger man, when the incidence is slightly higher, but not enormously, but it is higher. You have to bear in mind that if you were to choose active surveillance from this data set, and this is where the ambiguity comes in, because I can show you other data sets which give you slightly different numbers, but this is a fairly large and robust data set which says 60% of men who start being watched carefully will have changes, and those changes may be ones we notice with the PSA or the Gleason score, or they may be changes that the patient has, that they become more anxious and decide they don't want to continue to be watched. And that's an important consideration. 60% will start active treatment. And the one thing that worries a lot of men who are offered active surveillance is, well, how do you know the cancer won't get worse? And the answer is, of course, it may get worse. We know that roughly double the risk, but the risk is actually only 3.5%. And that risk is there whether you have any active treatment, active prostatectomy, radiotherapy, or active surveillance. It is a little higher in active surveillance, certainly, but nonetheless very small. And these are the concepts we're trying to get men to understand, and it's enormously difficult. And here you see, I think the response that I get. A lot of men on the left there are saying, well, look, I've got cancer. I think we heard it from Gary. I've got cancer. I don't want it to stay there. I want to approach it. I want to tackle it. I'm going to fight this and get rid of it. A lot of other men, of course, are perhaps more like others who say, well, I don't care. I just want to put my head in the sand and pretend it's never happened and see if I get away with it. And those are the extremes of response that we see. And somehow we have to help both men or both groups of men with those responses to find their way through and get the right treatment for them. Because actually, as I think I've just shown you, it doesn't matter at the beginning whether you aim to fight it or whether you put your head in the sand and have surveillance. What matters is that you are comfortable with what you're doing and that you're under careful observation. And if things aren't going to plan, we change course and give you the appropriate treatment. On the next slide, you see the basis that most people will make their decision upon. So I've reassured everyone that they will live just the same length of time, whether they have active surveillance, surgery, radiotherapy, or indeed any of the newer treatments. But they may all get some side effects, and this is just a cartoon depiction of the problems. You've heard of urinary leakage, difficulty passing urine, radiotherapy can affect bowel function and make it more frequent. Erectile function is always a concern, particularly for younger men, but also for older men, and it's important not to dismiss that in older men. And these are the problems we have to deal with, and unfortunately, some of these problems are permanent and those that patients will have to live with. And it's on that basis very often, I think, that patients make their decision. If we move on to the next slide, you'll see the sort of responses we get and how we have to handle that. So would it bother you to have to wear a pad every day? If you look at the data, which we will in a moment, many patients after surgery do. Would it bother you to have to open your bowels 3 times a day? Again, that can be a side effect of radiotherapy in about 1 in 3 patients. Is erectile function sufficient for intercourse important to you and your partner? And for many men, that's often the focus. On the next slide, the question is, well, what would you do? I always get that question. Yes, I usually duck it because what I would do is not necessarily the same thing that Gary or Andy would do. You've already heard different responses there. Excuse me. It does depend very much on personality. It depends very much on what your concept of it all. I think we heard Gary say he just didn't want it in him, and a lot of men tell me that they want to get rid of it, and they don't believe that having radiotherapy and certainly watching it is going to get rid of it. And that's emotionally that's important for them to know it's outside their body. Excuse me. There are other things we have to put into the equation. If you have a lot of urinary symptoms already, I think you did, Gary, and I think you did the right thing by having surgery, because radiotherapy doesn't make the prostate much smaller, and patients will continue to, excuse me, will continue to have urinary symptoms. Of course, we have to consider your general fitness for a big operation. And what about? I will keep going and it will stop. My apologies. What about your views on going into hospital? You know, some people, many men who are diagnosed with prostate cancer have never been to hospital before in their lives till they had a biopsy, and they will be terrified of going in for major surgery. Others are frightened about radiation. You know, they've heard of atom bombs and think it's the same thing. It is physically, but it's very different in terms of medical use. And there are logistic things. If you're asked to travel to the hospital every day for 4 weeks, instead of having a one-off procedure, that weighs heavily. And a lot of men say to me, you know, well, what's going to get me back to work quickest? And that is important, of course. So there are many of these things that come into the equation which are not related strictly to the medical, to the scientific interpretation of what's happening. Now, how do we unravel that? We go on to the next slide. This just shows you some of the data, and this is the sort of thing that we try and explain. But I don't know how well that shows. But if we just look at the top left-hand group of bars, you'll see that there are 4 bars, one of which represents the first one represents patients on active surveillance. The second one, those having a prostatectomy. The third one, the green one, is radiotherapy. The last one is a control group of men who hadn't got prostate cancer. So that's what you might expect to happen if you didn't have prostate cancer. And if you look at those bars, you see they're all roughly the same. And the group on the left means no pads are required. That patient doesn't have any urinary leakage. If you see that, whether you have active surveillance or radiotherapy, you're just the same as if you didn't have a diagnosis of prostate cancer. If you have surgery, it's a little bit lower, and I think most surgeons recognize that. Certainly most specialist nurses who are advising patients will tell you that. And you've got about a 60% risk of needing to or wanting to wear a pad, maybe just one a day, maybe it's dry at the end of the day, but nonetheless a change in your lifestyle. Similarly, if you look on the right-hand group of bars, if we look at firmness of the erection, and the ones on the left, the bar on the left is no erection function at all. Now, interestingly, if you look at the right-hand bar, that's the one of patients with no prostate cancer. That's higher than patients on active surveillance. Probably statistically, there's no difference. But what it means is on active surveillance, you can expect things to be just as it would be normally. And what that's saying is that something like 80% of men do have some erectile function. But you note the red bar again, that's the surgical bar, does fare a little worse, with some 60% of men reporting no erection at all. And this is long-term follow-up. This is over 15 years. And if we look at the far right-hand group of bars, where we're looking at erections firm enough for intercourse, you see that again, actually, men on active surveillance are doing better than the standard population. So in some way, they are selected. And that may be personality, that may be the fact they're younger men, perhaps. Who knows? But there seems to be something in that. Similarly, patients who have radiotherapy, a little bit lower than the control group. Surgical patients seem to have more difficulty with erectile function, and we won't focus in detail on the bottom 2. They're saying the same thing. So we can give you some data, but of course, the actual numbers will fluctuate between different populations. If we move on to the next slide, This is just trying to make sense of it all, and was from a large study looking at patients having active surveillance. And it recognizes that we're trying to balance this lack of certainty that active surveillance has. Um, you can't be sure what's going to happen. You don't know whether leaving the cancer is going to make it worse. Um, there's a lack of credibility often that you can have a cancer and just do nothing. That doesn't make sense, does it? You've got to really believe in the concept and equally um, be anxious to avoid the side effects, I'm sure. And that's where the resilience comes in. That knowing you're having structured monitoring, it's 3 monthly PSAs, it's regular MRIs, probably more biopsies, knowing you're going to be watched very carefully, trusting your team who are looking after you, knowing that if they say, look, it doesn't matter, we'll detect it if it's going to get more troublesome and we'll treat it effectively at that time, just as we can now. Family and support is important, and I think many partners, many children find it difficult to accept active surveillance, perhaps more so than the patients often. Knowing their loved one's got cancer and isn't going to have it treated is quite a difficult concept. And if we move on to the next slide, we see that anxiety and depression are actually relatively common. And there you see the the incidence is round about 15 to 20% of men having active anxiety or depression, more common in men who've been divorced than others. And on the next slide, we see a few more thoughts. I think both Annie and Gary demonstrated reassuringly a lack of decision regret. But decision regret is something we are becoming increasingly aware of. This is an enormously difficult position to put people into. And I often feel, look, it would be so much simpler if I could just say to you, this is the right treatment, have this one, even if there were others that were suitable. And so you'll always be a little bit uncertain. You'll always be looking back and saying, did I do the right thing? As indeed we all do with major decisions in our lives. That goes without saying. But this is one of the more pressing decisions you'll make, and it's active at that moment. And if you look here, you see, I don't know whether these what are called forest plots, whether they mean anything to everybody, but what it's telling me is that from a number of studies that have been shown there, around 20% of men asked 1 year later have what's been termed decision regret, distress or negative feelings that happen when you believe things would have been better if you'd made a different choice. And it's been shown that that's most common in men who feel they didn't have the opportunity to consider all the options and make an informed choice. So that's why this sort of webinar, the work of PC UK, is enormously important because it gives men that control. It allows them to have control over their decision with knowledge. And I think that's very important and has been shown to minimize the probability of decision regret. Of course, the other factor is those that have side effects. Inevitably, if a year later you're having to wear 2 or 3 pads a day because you're leaking urine, you'll look back and think, well, if only I hadn't had the surgery, this wouldn't be like this. Not really cogitating the other possibilities that may have happened. So I think there's perhaps one more slide. Yeah, this is again looking at decision regret and just saying it happens in around about a third of patients to some degree, 20%. Many more will have mild regret, and I guess that applies to every decision we make in life. And the last slide perhaps is coming. This is just to say it doesn't actually seem to matter what you decide. You still might regret it. And I guess that's not a very comforting thought at the end. But you see, there is a little bit less with active surveillance. It's around about 15, just a bit more than 15% of men will have decision regret after active surveillance. With prostatectomy, it's nearer 20%. With radiotherapy, it's nearer 20%. And I think that just reflects that you're more likely to get some side effects, which when you look back, you think maybe I should have had the other treatment with surgery or radiotherapy than active surveillance. and that small number may reflect those that went on to active treatment. So I've tried to give you an overview of my perception of the problem, and I do feel enormously sympathetic for you. Every clinic I will see 3 or 4 men in this position, and it's desperately difficult sometimes to help you through to find that right decision. I always tell them these things. It's not a fatal form of prostate cancer. I try and be comforting and say you may also certainly die of something else if it seems the appropriate thing. For some men, that may not be appropriate, of course. Any active treatment I offer can have side effects with long-term implications, and that's what you need to focus on when you're making that decision. But most men will have only minor, if any, effects from treatment. The other thing I try and emphasize to men, because at that point, it's a little bit like rabbit in the headlights. They've been told they got cancer. They think they've got to do something quickly and get it all treated. I try and reassure them that they really need to take time to make that decision. It doesn't matter if they take another week or two to see another specialist, to talk to the clinical nurse specialist, to read through all the information, just to get their head around it all before they make a decision. A week or two, probably a month or two, doesn't make a big difference to most men with early localized prostate cancer. But as we've seen, there are a lot of implications of just rushing into the first thing that they encounter. So I think I finished there, Jonathan. But we move on to this decision-making tool. So there are several of these out on the internet. And although we've been told not to look for Mr. Google, this one is approved. There is one approved by NHS as well. They all do the same thing, really. And this is derived from a large population of patients treated in the east of England. And as Shelley's just put in the chat, you can get the website from that. We seem to have stopped. We seem to have lost the actual. Oh no, here it is. Okay. So essentially what you get is this here, where you can put into here your own details. So if we say grade group, and this is as you were shown by Grace at the beginning. So we say grade group 2, which most men will be, Gleason 3+4, a PSA of, let's say, 12, that may be a little high for some, but it's not bad. A T stage, the vast majority of patients will have T2 cancer. It's visible on the MRI, but only just, it's localized. If you then press submit, it will tell you what Cambridge prognostic group you are in. You're in CPG group 3. And then it will tell you the treatment options. These options are all evidence-based treatment options. They're based on the NICE recommendations. So you will find that you may not have in here HIFU, for example, which isn't evidence-based and isn't NICE recommended. Many of the other focal treatments like cryotherapy, electroporation, and so on. But if we look at surgery, and if we just click on surgery, Hannah, what we get is a whole lot of detail on surgery. And if we just scroll down it gives you some detail. And then we go on to the risks and benefits. So it gives you the risks and benefits. It says, removes the cancer cells. This is likely to cure you. So that's the top line. That's the important thing most people want to see. But then we come down and we say, well, if you have a prostatectomy, at 6 months, 71 out of 100 patients will have problems with urinary incontinence. Okay, that means that they're dribbling urine. They will be wearing pads. If we look further on, at 6 months, moderate to severe urinary incontinence will be reported in 19 out of 100. That means they're really not holding their water well. It's not just a little dribble. And then we move on to the bottom one, which says at 6 years, it's only reported in 13 out of 100 patients. And that means that 87% of patients won't have urinary incontinence, but 13% will. And if we look at bowel function, you'll see there it's very unlikely bowel function is affected by radical prostatectomy, 1 or 2 patients in 100. But if we look at sexual function, we see that at 6 months, 66 out of 100 will have problems with sexual function, and at 6 years, 50 out of 100 will. And you can then look at a comparison. If you move on to that bottom panel, Hannah, that's it. And you can put them side by side. Yeah, just go ahead, Karen, that's fine. There you can see comparison of active surveillance and surgery and radiotherapy. What effect does each treatment option have on survival at 10 years? Well, as I hope you took as a message from my talk, and I hope you now see the data that says it really is true. At 10 years, 98 out of 100 patients offered active surveillance will not have died from prostate cancer. 99 out of 100 who had surgery will not have died, and 99 out of 100 had radiotherapy. So really, the cure rate is very, very high. And we can say, well, why is one saying 97, one saying 99? This is the challenge, the trouble with slightly ambiguous data coming from different places. But you can see it's very, very high. And then what effect does the treatment have on the cancer returning? So just because you're alive, you may be alive and the cancer's returned. And here you see at 10 years, 21 out of 100 patients offered active surveillance will have had active cancer identified and need to have treatment. But in those having surgery or radiotherapy, it's only 8, and they will be going on to further treatment. And perhaps you can go on to the toxicity now, Hannah. I don't mind which one we choose. We can see there urinary function. If you have active surveillance at 6 months, urinary continence, so in other words, holding urine normally, 39 out of 100 patients treated up active surveillance, 71 out of 100 offered surgery, and 38 out of 100 offered radiotherapy. So again, showing that with surgery, things are not quite as good. And if we go down to the bottom at 6 years, long-term, moderate to severe incontinence reported in 8 of 100 patients having active surveillance. So probably that's the level in the normal population of older men. 13 out of 100 with surgery, 5 out of 100 with radiotherapy. So you can say it's roughly doubled with surgery than the other treatments. That, of course, sounds terrible. But actually, if you say, well, it's about 5 to 8%, and there may be twice as much in surgery, it's not so bad. Of course, that's not to minimize the effect for those patients who are affected. And if you play with this tool, you can go through all the other toxicities as well. And indeed, there are panels which will show you these in nice diagrams of men colored one color or the other according to what happens. But for those patients who want to go into things in detail, I recognize a number don't. Quite a lot have got their head in the sand rather than the other group. Here are the facts. Here are the facts you can play with at home. You can put your own criteria in the beginning. You can see what the evidence says will happen. And this may be more credible than listening to a consultation. I think we all realize, we've certainly been told many times, that your recall from certainly the first consultation with an oncologist is something around about 50%. And that's why we send you away with lots of written information and lots of contact numbers to come back to us, because it is a very difficult situation from the patient side. And whatever we do to allay the fears and to try and present information in a rational way, it's difficult to take it all in. And tools like this, I think, are enormously useful for those who are that way inclined. They're open access, anyone can use them, and they are a little more valid than Dr. Google, shall we say. So, Jonathan, I'll leave it there, I think, and leave you to carry us on.
Thank you very much, Peter. That was a brilliant talk. I think it's really highlighted the fact that it's not just as simple as working out whether the treatment will cure the cancer or not. You know, there are so many lifestyle choices that men have to consider about what is most important to them. And I'm sure that talk has given the people watching this webinar lots of things to think about. I'm just going to welcome back Grace briefly before we start our Q&A session properly. She just wants to kind of give an overview of some of the services that are offered by Prostate Cancer UK that you'll have heard mentioned throughout the webinar. Over to you, Grace.
Hi everyone. So a couple of just our resources at Prostate Cancer UK. You've probably heard about some of them throughout the talk. So obviously I'm one of the specialist nurses. There's a whole team of specialist nurses at Prostate Cancer UK that you can call to ask any questions for information and support. But you can also email us. We have live chat, we have WhatsApp as well. So there's different ways of communicating. So whatever you feel like might be best for you. If you don't feel like picking up the phone, sometimes writing an email can help. So that's the Specialist Nurses Service, and you can find out more about that at prostatecanceruk.org as well. We also talked about our peer support service as well with Gary and Andy. So that's where we match men with other men who've undergone these treatments, and we can try and match you as closely as possible. So that can be done either by calling one of the specialist nurses, or you can do it online as a form and submit kind of your details to try and match you as closely to another man who's undergone these treatments. We also have so much health information on our website as well, whether it's specifically around these different treatments or whether it's around our wellbeing hub about how to kind of deal with having prostate cancer and the diagnosis around kind of emotional and physical support as well. And we have our online communities as well, where you can chat and interact with other men and ask different questions as well. So there's lots of resources, and I'm sure there's lots of other things as well that we offer that I haven't thought of the top of my head. But please call us if you need any information or support, and we can try and really signpost you specifically to things that might be helpful for you in helping make this decision.
Thank you, Grace. So now we're going to start our Q&A session. Hopefully all of our panel will be joining us on the screen. So I'll just give it a few minutes for everybody to be spotlit. Thank you for the questions that have already come in. A lot of you have submitted questions, and the nurses in the background have selected a few for me to go through now. So I'll start off with the first one. This is more for our clinicians, I believe, and someone has asked, how reliable is the Gleason score? Is it precise and is it consistent?
That's a very good question, which is what everyone says when they don't know the answer. The Gleason score is a description by the pathologist. It's not a measurement. So it's how he sees the cells, or she sees the cells, of course, and whether they are similar to ordinary prostate cells or whether they're very, very different. And that gradient is the gradient that gives you a different score. It's very, very different. It's score 5. It's very similar to normal prostate cells. It's score 3. We don't get score 1 or 2 anymore. That's been outlawed, I think. So the actual measurement is quite reliable. And indeed, there have been studies where pathologists send the samples to another pathologist and they look at them, and there may be some subtle changes. We often review pathology from other hospitals, and where one pathologist says 3 + 4, another may say 4 + 3, but in general, they are within the same ballpark, but they may change in detail. The bigger difficulty is that, and I think it was, I can't remember, perhaps it was Gary who said that he started off with Gleason 3 + 3, and then he ended up with Gleason 3 + 4, and the problem is that it's based on a needle going through a small part of an organ that is about 50 mils in size. So there's a sampling issue that says if you took a bit from the one next door, would it be exactly the same? And we know when we look at prostatectomy specimens that if we look at across them, there will be several patches of prostate cancer in most cases. Occasionally, it's what we call focal and limited, and some will be of different grades to the other. So there is a difficulty there in taking the sample, and urologists will often say, well, we expect it to be at least 1 grade higher in the prostatectomy than it is on the diagnostic biopsy. So I think the diagnosis is accurate, but the implications and the meaning of it need to be interpreted.
Thank you, Peter. And then this question kind of follows on nicely when we're talking about, sampling issues with biopsies. But this is, has the reliability of MRI scanning improved over the past 10 years?
Yes, is the straight answer. So, yeah, I mean, MRI scanning has improved enormously to a point where now people are saying, well, in surveillance at least, MRI scanning is not displacing biopsies. Biopsies will always be the gold standard, but can at least allow some men to avoid the horror of a regular biopsy, which you know, every week I will have 2 or 3 men telling me the biopsy was the worst experience of their lives. And partly I think that's because of the procedure, how it's done. But anyway, so yes is the answer. They've improved enormously. There are various technical aspects that have changed. They're better scanners. They're more precise. And there are sequences. In other words, they can look at different characteristics of the tissue, what are called functional sequences, which give more information than just looking at the structure of it. And you may have heard of bimodality or trimodality, multifunctional MRI, which is said to be the gold standard now, where you don't just look at the structure, but you look at least one other type of MRI, which is looking at blood flow, perhaps, or the amount of water in any part of the gland, and those things give additional clues as to interpret the appearances of it. So yes, MRIs have improved enormously in the last 10 years.
Great, thank you, Peter. Right, we've now got a couple of questions for Gary and Andy. So the first question is around your partners and the involvement they played in kind of the decision-making process. How much of an influence were they on your decision? Yeah, and how involved were they? Andy, I'll come to you first if that's okay.
My wife was a great influence because she came to every appointment with me. We talked about all the information we've been given at the time. We talked through it together, the implications on our lives, the implication on our children's lives, because our boys were only 8 and 12 at the time. So, yes, I mean, it was at her insistence that I went to the GP in the first place. So if she hadn't been as insistent as she was, then it sounds over dramatic, but I may not have been sat here on this webinar this evening.
Thank you, Andy. And same question to you, Gary.
Yeah, my wife, she was been with me all the way from right to the beginning. What I found when you go and speak to your urologist, obviously in the early days, and especially when they tell you what diagnosis you've got, they give you a lot of detail. Your mind's blank. And to be honest with you, if I wouldn't have had my wife at side of me, and she'd been right from the beginning, I wouldn't have digested half of what was told to me. So I think that alone, it really, really does help. So I think anybody who's going through this at an early stage, I think having somebody, whether it's your wife or whether it's a close friend or whatever, is really important.
Thank you, Gary. And then the next question to you both is, and we've touched on it a little bit, I think, in the interview sections that we had with you, but what were your kind of main priorities in making your decision? Was it the consideration of side effects? Was it that thought of wanting to get rid of the cancer? What was like the main driver? Andy, I'll come to you first again. I'm sorry, Gary.
I just wanted the situation to be to have the best possible outcome for me. And I gave the reasons why I didn't opt for surgery, because it wasn't the robotic surgery which is currently available. And the radio and hormone therapy seemed to be the best option for me at that particular time, especially when the oncologist said either option would provide you with the same outcome.
Thank you. And Gary, would you like to add to that?
I think for me, I obviously off back of talking to the nurses and the urologist, the surgery obviously was my choice, and what kind of was told me, I was informed that surgery when you got to a certain age, I think he said it was 72 at that time, wouldn't be an option. So I thought, well, if I'm going to have surgery, I was 62. You're better off having it while you're fit, healthy, because you never know what happens. If you get any other illnesses on your way to, as you get older, surgery sometimes couldn't be an option. The other thing as well is you always got that backup as well as radiotherapy. I think the other way around, and I think, I'm sure that I think this is right. If you had the radiotherapy, then you decided to say, well, can I have surgery? I think that's more difficult to have done. So that's kind of, that's a reason why.
Great, thank you, Gary. And actually, that's one of the questions that's come up, so I'll pass that straight over to Grace now. So, is it true that if the cancer comes back after surgery, you can have radiotherapy, but if it's the opposite way around, there are more issues?
Yeah, so it is more common that if people were to have surgery, then if a prostate cancer was to reoccur, that then you could have further radiotherapy to areas such as the prostate bed or any surrounding lymph nodes if it's reoccurred to those areas. It's not as common to then have radiotherapy again to an area that's had radiotherapy, but it does depend on how many fractions or grays of radiotherapy that you've had. To be able to have surgery after radiotherapy um, is less common because radiotherapy can sometimes alter or change kind of cells and make them what we call kind of sticky is a good way of kind of explaining it. And therefore going back into that area and trying to do surgery can mean that it's just slightly more difficult. I think it depends on kind of your individual circumstances and what your consultant is saying to you. It's just as a general rule, it is more common to be able to have surgery and then radiotherapy to that area rather than having radiotherapy and then surgery afterwards.
Great, thank you. And then I've got another question for you, Grace, and that is there anything I can do in preparation before starting treatment? Should I change my diet, or is there any special exercises that can be done?
Yeah, so it depends on your treatment. In general, for diet, we say that kind of a diet that's good for your heart is good for your prostate. So kind of having a healthy base, your balanced diet. We know that having a healthy diet and exercising are all things that can help being kind of as fit and healthy as you can before you undergo any treatments. We know that's not necessarily the case, and it's not easy for everyone, depending on how old they are or kind of if they have any other medical conditions going on as well. Things that typically can help. So, for instance, surgery, sometimes being able to do pelvic floor exercises before surgery might be able to help. And we do have a kind of a whole web page and fact sheet about that men can access. Um, then they can carry on with pelvic floor exercises post surgery once the catheter's removed as well. So there are kind of little things, but in general, kind of being, eating a healthy, balanced diet and maintaining some form of exercise before any treatment is helpful.
And
Great,
stop
thank you.
smoking.
Yes, yeah, obviously, the smoking and alcohol, obviously things that are not necessarily kind of recommended, and we all know that necessarily they're not good for us. So trying to cut down on those things can help.
Okay, thank you. And then this next one is possibly for Grace, possibly for Peter, but this person says, I haven't been told about brachytherapy and I'm not sure if it's available in my hospital. Is it possible to be referred elsewhere?
The straight answer is yes. Um,
Yeah.
and I think in most areas there is a hospital not too far away that will be offering brachytherapy.
Okay, and I suppose a follow-on question then would be how would they go about doing that? Do they just talk to their existing hospital? How do you initiate that referral?
I mean, in my experience, if you talk to the clinical nurse specialists, they're usually the best to intercede, as it were, and they can negotiate a referral. Grace, you may have more experience than I do.
That's absolutely the case. Speaking to your oncologist or the clinical nurse specialist at the hospital, they would be able to then put you in contact and refer you onto a centre that would then be able to assess if you'd be appropriate for that treatment and if they'd be happy to do that treatment for you. And usually, because it's in your local area, they'll be then able to refer you to a place that's closer rather than further away.
Okay, great. I think this might have to be the last question, bearing in mind the timings, and it's something that's been Peter, you touched on, but I think it's really important to reiterate it again, is how quickly do you need to make a decision about treatment?
Well, how long is a piece of string? Yeah, I mean, I always tell patients it doesn't matter at all for the cancer, it's their peace of mind. And I think it's true to say that most men and their families, once they've got a plan, once they've made that decision and they know where they're going, feel much more comfortable. But I do emphasize that they can take, some weeks to decide without losing ground at all. Again, it's then there's a credibility issue. I mean, unfortunately, all the sort of media around cancer in general is diagnose it quickly, diagnose it early. NHS targets are 31 days, and it's not quite the same with prostate cancer.
We have two more questions have come in, so I'm going to try and squeeze them in as quickly as possible. So the first one is, how common are emotional problems following hormone treatment?
Do you want me to take that one,
Yeah,
please?
yeah, if you're happy
Yeah.
to take that one, Grace.
It's quite a common side effect from hormone therapy. We speak to a lot of men on the phone, particularly kind of at the beginning when they're first started on hormone therapy. Um, it's from the lack of testosterone, so it's really messing around with your hormones and stopping that production of testosterone, and it means that you can feel more emotional. It means that sometimes you can feel more, have more anxiety. Some men can feel more low in mood and sometimes can have depression and things. And these emotional changes can be really difficult. I think the important thing is knowing that this could happen, explaining this to friends and family as well, and then trying to find a way to kind of support yourself with these emotional changes. For some men, that is, making sure I get outside in the morning and have a walk, or making sure that I connect with friends more slightly over the week to help with kind of these kind of emotional problems with hormone therapy. And normally we do speak to men that these get better over a period of time and that they learn to manage these kind of emotional problems with hormone therapy as well. But if you're worried about that at all, please give us a call. We're more than happy to speak to you about that as well.
Great,
I
thank you.
think it's important to emphasize most men will be in some sort of emotional turmoil.
Yeah.
And it just partly it's time, and then yes, the hormones make it worse. Grace, absolutely right. It's not just the men on hormone treatment who do have that challenge.
Okay, and then the final question, which I think is best answered by you, Peter, is why is PSA used rather than PSA density that takes into account the prostate size or volume to guide decision making?
I think PSA density is used in terms of diagnosis, but it's not an absolute measure. And so the whole controversy around PSA screening is that it's not a very specific test, although it's very sensitive. In other words, you find a lot of men who don't have prostate cancer. PSA density improves that pickup rate. But once you've had treatment for prostate cancer, of course, either you don't have a prostate, or you've got a diminished prostate from whatever treatment you've had. And so the volume measure is no longer valid. So it's main use, and I think it does refine certainly practices I have. PSA density is often used to determine whether men who are on borderline should go for an MRI, go for biopsies, rather than just be watched further.
Great, thank you. So that's all the time we've got for the Q&As this evening. So I just want to end with one final poll, which I will bring up now. I think this might be the results from the initial one, so apologies for that. Let's see if I can. Here we go. This bit always confuses me. Apologies. So here we go. One final question. How would you rate today's webinar? Excellent, good, fair, or poor? And please be as honest as you would like to be. If it hasn't been good today, we want to be able to improve these so that they are. Just give it a few minutes for people to answer. Okay, I will end it there. Thank you, everybody. And then I just want to say a huge thank you to all of our panel, to Grace, to Peter, and to Andy and Gary for sharing their stories and for offering so much wisdom and insight into their situations. I know it will be greatly appreciated by everybody listening tonight. Please keep an eye on your inbox over the next few days. We'll be sharing a survey to ask you how you found this webinar in a little bit more detail. Your thoughts are vital in helping us share information and support, so please take the time to do this. We also hope to be able to share a recording of the webinar within the next few days. It'll be on YouTube and it will also be on our Prostate Cancer UK website, and there'll be a link to it in the emails that get sent out as well. I'd also like to highlight our new Prostate Health Hub. So this is a new support and information email service that we've created to help men live well with and after prostate cancer, and we'll be launching it within the next month. You can sign up for it on our website within the Get Support section. Shalu should have just dropped a link to it in the chat, but we'll also include it in the follow-up email so that you've got plenty of time to sign up for it. Please don't forget there's a wealth of prostate cancer information on our website, and our specialist nurses are available Monday to Friday, 9 to 5 on 0800 074 8383. Please keep your eyes peeled for our next webinars as well. We'll be sending out invites via email for our next one, which is scheduled for April, which will focus on radiotherapy and the side effects of treatment. Have a good evening, everybody, and take care. Thank you for attending.